Hello, hopefully, oh, it looks like it's recording this time. This is my round 2 of pharmacology, just trying to organize it into an audio for everyone to listen to, and mostly myself, because I like audio to listen to when I study. Anyway, we're going to talk about the psychopharmacology, and the way I broke it out and on my flashcards is I used the ATI book as well as these slides to kind of base my studying off of. But there was no audio for it. We did the worksheet in class. So the way that I did my flashcards is that I wrote basically the class and the type on the back, and then on the front, and then on the back I wrote down what neurotransmitter is used, why, or the treatment or the indication for it, the adverse effects, and then some examples of the medication, because she wants us to know the class and not necessarily like know each drug and know what class they're in, but like think about antipsychotics, and then if she gives you, haloperidol, that that's a first generation, and that's all the issues and benefits that come with that. So to get started, we'll talk about antipsychotic drugs. And in the first generation antipsychotic drugs, this is known as either first generation, typical, or conventional antipsychotic drugs. And the neurotransmitter that's used, or the mechanism of action for first generation, is that it's a strong dopamine inhibitor. And it's used for treatment of positive symptoms and aggressive behavior. And for positive symptoms, those are things like agitation, delusions, or hallucinations. So it's used for positive symptoms of like schizophrenia or any other psychotic issues. Some adverse effects for first generation is that it has the highest incidence of EPS, or extrapyramidal syndromes, and we'll go over that after we talk about all the generation. It has an increase in prolactin secretion, so it has endocrine issues, and increased prolactin leads to gynecomastia, which is breast development in men, galactorrhea, and amenorrhea. It has anticholinergic symptoms, which is the can't spit, can't sit, can't shit. I forget all the S's, that she talked about in class. Basically, it like dries out your mucous membranes, because on top of dopamine, it also affects like histamine, and that's why you have the anticholinergic effects of like dry mouth and stuff you get. You have problems with orthostatic hypotension, sedation, and agranulocytosis are things you want to watch out for. Some examples of first generation drugs are Thorazine, which is chlorpromazine, which I can't pronounce most of these medications, but Thorazine, and then haloperidol, which is Haldol, and then thioxylene, which is Naveen. So I think the main drugs that she might use is Haldol and Thorazine. So she talks about Haldol or Thorazine, it's a first generation drug. For second generation antipsychotics, they're also known as atypical drugs, and they work by blocking serotonin reuptake and a very little bit on dopamine. So first generation works strongly on dopamine, and second generation works by blocking serotonin reuptake. Second generations are used in the treatment of positive and negative symptoms of schizophrenia. So the positive, again, is the agitation, delusions, and hallucinations. And for the negative symptoms, it's like the social withdrawal, the decreased emotion, decreased energy, decrease in motivation, and like flat kind of affect as well. Some adverse effects of second generation drugs are that it has a mild EPS versus the first generation that has a high incidence of EPS. It has metabolic issues like diabetes, mellitus, and weight gain, your increased chance for cardiac disease, You have orthostatic hypotension issues, anticholinergic, and sedation as some of the adverse effects. Some examples of second-generation drugs are clozapine and risperidone, ziprasidone, which is Geodon, and quetiapine. So clozapine is the Clorazil, risperidone is risperidol, quetiapine is Seroquel, and then ziprasidone is just Geodon. For third generation, you see that down at the bottom there, is different than the other ones, and it works by the third generation is kind of an adjunct therapy to bipolar and depression, and it works by stabilizing dopamine levels. So if they get too high, then it'll lower it down, and if dopamine levels are too low, then it'll increase dopamine. Some adverse effects is that it has very little or no EPS. You have a less risk for metabolic issues, anticholinergic and orthostatic blood pressure. It does have some sedation, headache, and anxiety are some of the issues. So to compare and contrast first generation, second generation, and third generation, first generation is a strong has strong dopamine inhibitor. Second generation blocks serotonin reuptake and a little bit of dopamine. And third generation is basically a dopamine stabilizer. First generation is used to treat positive symptoms and aggressive behavior. And those positive symptoms are agitation, delusions, and hallucinations. Second generation treats both positive and negative signs and symptoms, which the negatives is the social withdrawal, the flat affect. And then the third generation is an adjunct therapy to bipolar and depression. And the adverse effects for each one. So for first generation, you have high increase of EPS, prolactin, anticholinergic. So first generation has a lot of issues, higher adverse effects. Second generation has a milder EPS effect, but has metabolic issues like weight gain and diabetes issues, along with the orthostatic hypotension and anticholinergic and all that. Third generation has very low or no EPS, decreased risk for metabolic and anticholinergic effects. Some examples of drugs from each. So first generation, you have your Thorazine and Haldol. Second generation, you have your risperidone, your clozapine, and your Geodon. And third generation, you have Abilify. In those EPS that we talked about, the extrapyramidal, I don't think there's a slide for it, but you have acute dystonia, which is severe spasms of like the tongue, neck, face, and back. You have Parkinsonism, which basically mimics Parkinson's disease. So you have like a mask type face, you have a shuffling gait, tremors. You can those pill rollers she talked about. So people like to roll the pills between their fingers, and drooling. Then you have the akathisia, which is basically people that are very like restless and agitated and pacey, like they pace around the room, like they can't ever settle down, they're always agitated. Then you have neuromalignant syndrome, and neuromalignant syndrome causes rigidity. You can have a sudden spike in temperature. You have very labile blood pressure that can go up and down. You have altered level of consciousness and coma that can result from this neuromalignant syndrome. And then later on in EPS, so this is a late sign of EPS, is tardive dyskinesia, which is basically involuntary movement of the tongue, face, arms, and legs. And this is irreversible. So when we're talking about first generation having a high EPS, we're talking about acute dystonia, Parkinsonian, akastasia, neuromalignant syndrome, and Darf dyskinesia. So first generation has a high incidence of these. Second generation has mild EPS, and third generation has very little or no EPS effects with it. And then the next thing I have to talk about is lithium. And lithium is a mood stabilizer, and it's used, its mechanism of action is a serotonin receptor blocker. And it's used for the treatment of bipolar disorders. In the slide here, it says that its mechanism is not well understood, but in the ATI book, it talks about serotonin receptor blockage. And its treatment is for bipolar disorder. And some things that we need to know about lithium is that it's a natural occurring salt. So we need to be very careful about our fluid balance, how much water we're taking in and how much is going out. Because wherever sodium goes, water will follow it, basically. It's very hydrophilic. It loves water, moves around. Some other important facts. So we need to make sure that we keep a balance. We also have a very narrow therapeutic window for lithium. Lithium is very toxic. So we need to make sure that we stay within that therapeutic window for it. So if you are taking lithium, you should be wearing a medical alert bracelet or some sort of identifier that says that you're on lithium for bipolar disorder or whatever mood stabilizer that you're using it for. Some adverse effects for lithium are GI upset, fine hand tremors, polyuria, which is frequent urination, increased weight gain because wherever sodium goes, water will follow. So if you have higher sodium level, you can gain water weight. And then you're also at an increased risk for renal and thyroid diseases as well. And the next mood stabilizer, anticonvulsant that we're going to, or mood stabilizer we're going to talk about is Depakote, which is what we talked about last week in 110B. Which is valproic acid. So valproic acid is a mood stabilizer, anti-epileptic drug as well. And how that works is that it potentiates GABA. And GABA inhibits glutamate, which decreases the CNS excitation. So basically it depresses or doesn't allow your central nervous system to get excited. And this is treated or used for the treatment of bipolar disorder. Lithium is used for bipolar disorder, but this particular drug, Depakote, is used best for the manic or mania and rapid cycling stages of bipolar. Some adverse effects of valproic acid are GI upset, and the other severe signs and symptoms are not very common with this particular drug. So those are your mood stabilizers. So you have the antipsychotics, first, second, third generation, and then the mood stabilizers, which is the valproic acid and the lithium. And now we're going to talk about antidepressants. So SSRIs, or serotonin selective serotonin reuptake. I can't talk. Basically, this blocks FHT, or 5-HT, which is serotonin, the marker for serotonin reuptake, which increases serotonin availability in the brain or central nervous system. And SSRIs are the first choice in antidepressants because it's very effective, for one, and two, has very low adverse effects compared to the other antidepressants. However, it does have a higher incidence of sexual and GI side effects. So as we go through all the different antidepressants, you really have to weigh the pros and cons of the side effects. What's really good about this SSRI is that they have very low risk for harm and abuse, so they're not really addictive as some of the other antidepressants. What you do need to watch out for SRIs, though, is combined additive effects with antipsychotics and lithium. So if you take an SSRI with lithium, you're going to have increased levels of lithium in the system. So you would want to watch out for that. And lithium is very toxic. And then with SSRIs combined with antipsychotics, you have an increased risk for developing EPS. So if you have a first generation antipsychotic, like Haldol or Thorazine, and they're taking SSRI, then you're at a very high risk of developing EPS as well. With SSRIs, you really want to be careful about taking them with MAOIs, tricyclic antidepressants, or St. John's wort. And with most antidepressants, you do not want to stop suddenly. It can cause some major neurological issues. So you want to taper off medication slowly. Some examples of SSRIs are Prozac, and sertraline, which is Zoloft, and Lexapro. Fluoxetine, which is Prozac, sertraline, Zoloft, and Lexapro. Tricyclic antidepressants are next. In this slide, it talks about some other novel ones, so ones that aren't used as often. We talked about them a little bit online, like Wellbutrin is used for like a smoking cessation and stuff like that. I didn't really go into these in too much detail. I figured that the main ones were mostly the ones that we needed to focus on. So for TCAs, or tricyclic antidepressants, these work by mainly blocks norepinephrine reuptake, but it also affects serotonin. So for SSRIs, it works mostly on serotonin, and then TCAs, it mostly works on norepinephrine. And it's used a little bit differently. So TCAs work on depression the same way that antidepressants, or not the same way, but work the same way that SSRIs work. But it also treats chronic pain and fibromyalgia as well, compared to the SSRIs. So the TCAs, some adverse effects that you have are increased cardiac toxicity, which can lead to a whole range of problems. It decreases your seizure threshold. Then you have the anticholinergic and orthostatic blood pressure issues. You have with most antidepressants, you have a high suicide risk because 1 week supply of TCAs can be very lethal and could kill you. And these aren't used as much anymore because the adverse effects are so significant. Some examples, though, of TCAs are amitriptyline and Remeron, Senequin, and Pamelor, or nortriptyline. I think the main one here is the amitriptyline. So when you compare SSRI to TCAs, SSRIs deal mostly with serotonin, and TCAs deal mostly with norepinephrine. SSRIs have very low adverse effects and potential for harm or abuse, but TCAs have significant side effects, including heart problems, seizure issues, orthostatic blood pressure, and is very lethal. The third antidepressant we're going to talk about is MAOIs, or monoamine oxidase inhibitors. And basically what that does is it blocks monoamines from destroying your neurotransmitters like norepinephrine, dopamine, and serotonin. So you have increased levels of all of these in your system. And so MAOIs are used as treatment for depression and bulimia when the other two antidepressants have failed, so they weren't working. Um, Adverse effects for this are also pretty significant. Um, for MAOIs, you can have hypertension or a hypertensive crisis, which is very life-threatening and requires emergent intervention. Um, you have CNS stimulation because you have all of the neurotransmitters just floating around there, and then also rash is one of the side effects. To help with the hypertensive crisis, you want to avoid triamines, which is cheese, beer, wine, aged meats. With that, with taking MAOIs. With MAOIs, if you were given Demerol, it could be very fatal. So again, if you're taking things like lithium or an antidepressant like MAOIs, having something like a medical alert bracelet saying that you're taking that is very smart, a very smart thing to do. MAOIs interact with a lot of different types of medication. Some examples of MAOIs are phenelzine, which is Nardil, or isocarboxide, which is Marplan. So between the three antidepressants, the first choice is going to be SSRIs. They're effective. They work on serotonin. There's a decreased risk of abuse and harm. Second generation, or not second generation, TCAs are used primarily for depression, and they block norepinephrine, but they're very lethal and not as widely used. And then MAOIs are used when all the other ones fail, and they all work on depression. They're called antidepressants. And then we have anti-anxiety. So benzodiazepine works by increasing GABA effects. And GABA basically decreases the neuron's response to excitatory neurotransmitters like dopamine and things like that. So it acts as a CNS depressant. So benzos are a sedative, hypnotic, anti-anxiolytic. It's used for short-term treatment or as needed, PRN, for anxiety, panic attacks, seizures, insomnia, and for alcohol withdrawal. Some adverse effects is that it's very addictive. It decreases your CNS and can cause a paradoxical response with people with older, their kids that are older, or people that have brain problems or injuries. Romazicon is a reversal agent for benzos, and it reverses a depressed respiratory system and sedation effects that it has. Some examples of benzos are Xanax, or diazepam, Valium, Ativan, which is lorazepam, or Librium. The second anti-anxiety that we're going over is busoprone, and this has an affinity for serotonin and dopamine receptors. It's for treatments of like panic disorders like PTSD and OCD. It's non-sedating and non-euphorics, and it's very low non-habit forming, and you don't have withdrawal symptoms from it. It's contraindicated for MAOIs. So if you are on MAOI and you're going to start busoprone, you would want to wait 14 days for it to wash out. So the difference between busoprone and benzos is benzos are a sedative that work on GABA, which decreases the response to excitatory neurons. And bustaprone is an atypical non-barbiturate analytic, or not analytic, anxiolytic that affects serotonin and dopamine themselves and not the whole CNS. So benzos are a CNS depressant treatment, like short-term treatment of panic disorders and anxiety, and bustaprone is a treatment for panic disorders and PTSD. Adverse effects for benzos are the additive or addictive effect, CNS depressant, and paradoxical response. And you don't really have that with bustaprone. Bustaprone is non-sedating, non-euphoric. And that's really all I have for everyone. I hope that helps. And I will talk to you all later.